All right. All right, if you have watery diarrhea after food and you have a osmotic stool osm greater than 50, it's likely osmotic diarrhea due to lactose intolerance. Life-threatening GI questions. If you have a GI bleed that's stable, you have hematochezia, get a colonoscopy. If you have unstable hematochezia, you need to do an EGD plus angiography or colonoscopy. If you have vomiting, intense vomiting plus hematemesis, chest pain, pleural effusions, pneumothorax, hemodynamic instability, that's a transmural tear or Boerhaave. You want to use water-soluble or barium esophagography. Treat it with acid suppression, keep them NPO, antibiotics, and emergency surgery consult. That's opposed to hematemesis and intense vomiting without so much chest pain, and that's Mallory-Weiss. You still want to do an upper GI procedure that's diagnostic and therapeutic if you see a bleed, plus acid suppression. Abdominal pain, vomiting, lipase, high bilirubin, think gallstone pancreatitis, so get an abdominal ultrasound. To confirm if there's any biliary dilatation, you want to do an elective cholecystectomy. And if there is bile duct dilatation, get a CT abdomen with contrast to scan for any pancreatitis. Diarrhea continued. If you have acute diarrhea, that's less than 14 days. Usually it's viral, causes something watery. If you have acute bloody diarrhea, then you want to get fluid and stool studies. Treatment for acute bloody diarrhea is with antibiotics only if it's severe disease, elderly, immunocompromised, severely hypovolemic, or if it's prolonged more than 7 days, and if you've identified the bacteria. Acute pancreatitis could be biliary, alcohol, triglycerides, autoimmune. If it's autoimmune, you want to treat it with steroids. If it's something like drugs, like TZD or diuretics, could show dilated bile ducts. If they have a fever, jaundice, altered mental status, hypotension, that's acute cholangitis. You want to do an ERCP for acute cholangitis for life-saving biliary drainage plus antibiotics. Criteria for acute pancreatitis is pain, imaging, and lipase. Treatment is keep them NPO, fluids, ERCP if there's a bile duct stone, cholecystectomy. Might even need to do apheresis for triglycerides, insulin, fibrates. The best predictor of pancreatic disease, BUN, age, obesity, hematocrit, CRP, elevated hematocrit reflex third spacing. Acute pancreatitis that doesn't resolve gets what imaging test? Gets CT abdomen pelvis with contrast. You might need to see a pancreatic necrosis. Treatment for that, IV antibiotics, meropenem, quinolone, metronidazole. If you have chronic pancreatitis, you can diagnose that with what study? MRCP. That shows scattered calcifications. If you have ultrasound positive for gallstones with bile duct dilatation, you have choledocholithiasis. And without surgical abdomen, that may lead to acute cholangitis. Treatment for acute cholangitis, ERCP plus antibiotics. Elective cholecystectomy later. If you have ultrasound negative, you have inconclusive pancreatitis, then you get a what scan? HIDA scan. If you have diarrhea that's chronic, that's more than 4 weeks, acute is less than 4 weeks. Chronic diarrhea can be inflammatory or non-inflammatory. You want to get electrolytes to determine if it's osmotic or secretory. Less than 50, secretory. Starts with an S, 5 looks like an S. And you want to get microscopy fat content. If it's greater than 50, that's osmotic, malabsorption. Could be celiacs. Celiacs will have chronic diarrhea and anemia. Other autoimmune diseases, high osmotic gap. Get a serology screen to find transglutaminase IgA or endomysial IgA. You might also see herpetiform rash, followed by an endoscopy for confirmation. The endoscopy biopsy will show villus atrophy. The treatment is what? Gluten-free diet. Prevention of osteopenia, pneumococcal vaccine, dapsone if you have dermatitis herpetiformis, multivitamins due to deficiency. It's important to remember what cancer was celiac. Lymphoma, EATL, at the jejunum, prevents absorption. You have B symptoms, weight loss, fever, as well as overgrowth causing bowel obstruction, and GI bleeding. Again, lactose intolerance, high osmotic gap, diagnosed with what test? Lactose hydrogen test, hydrogen breath test. That's compared to SIBO, which is B12 deficiency, plus a lactose breath test or carb breath test, sometimes seen with scleroderma. If a patient presents with a vascular path history, CAD, diabetes, hypertension, and bloody stools, think of what? Acute colon ischemia. Usually secondary to a low flow state caused by the atherosclerosis. They'll have a history of abdominal angina, signs and symptoms of painless hematic bleeding per rectum or hematochezia, diarrhea. On labs, they'll have lactic acidosis from the ischemia. What kind of imaging findings you'll see on CT? You'll have fat stranding, wall thickening, and endoscopy shows edema. Treatment for colonic ischemia, IV fluids, bowel rest, antibiotics, and if there's necrosis, resection. Acute mesenteric ischemia is pain out of proportion with no peritoneal signs. Best test is a CT angiogram. Acute mesenteric ischemia usually progresses from ischemia to an infarction, which then does become acute abdomen, distended abdomen, absent bowel sounds, peritoneal signs. So it's a spectrum. Acute mesenteric ischemia progresses to infarction. Etiologies are occlusive, like a thrombus or embolism from AFib, volvulus, or intestinal strangulation. Non-occlusive is hypoperfusion states, blanketing hypoperfusion, low cardiac output. You can have chronic mesenteric ischemia. The gold standard test for that is what? CT angiography. Same as acute ischemia diagnosis. Diverticulitis, treated with antibiotics. If it's uncomplicated, if it has strictures or an abscess or obstructions, then it's complicated. And you want to treat it before doing the colonoscopy. Cancer, if you have an average cancer risk for colon cancer, you want to screen at age what? 45, every 10 years, or Q5 for colonography, or Q3 for FIT, F-I-T, Q3, with a DNA, 3 letters with FIT and DNA, or Q1 FIT. However, if you have a first-degree relative with colon cancer or high-risk adenomatous polyps, you want to start screening at age 40 or a year or 10 years prior to when the relative have whichever one came sooner, because that increases your risk of colon cancer by 2 times. And you want to get colonoscopy after you're diagnosed with ulcerative colitis. How many years after? 10. And then you repeat it how often? 3. If you have signs of heartburn, indigestion, dyspepsia, heartburn management depends on the age. So if you have all these symptoms at age 60 or greater, you want to do what? An upper endoscopy. If you have these symptoms at less than age 60, you want to test for what? H. pylori. If positive, then you treat for H. pylori. Unless they're young and high risk, then you want to get an upper endoscopy. Upper endoscopies for greater than age 60 for gastric burning, indigestion, dyspepsia. And if you're less than 60, if you have high risk things like a GI bleed or weight loss, unexplained anemia, mass that's palpable, or progressive dysphagia from solids to liquids, or family history of GI cancer. Cancer of the esophagus in the upper is usually squamous, and the lower is usually adenomatous. Barrett's without dysplasia. How do you treat that? Acid suppression and endoscopy in 5 years. If you have Barrett's with low dysplasia, how do you treat that? Acid suppression and watch with an endoscopy in several months. If you have Barrett's with high-grade dysplasia, treatment for that, endoscopic eradication. That's the reason why we treat GERD, because GERD could lead to badness. GERD can present as throat irritation, hoarseness, chest pain, can mimic ischemic chest pain of the heart, and cough. So it can mimic upper airway syndrome or even a lisinopril cough. And GERD is worse with food or alcohol. Treatment is initial lifestyle changes, diet changes, and then acid suppression with a PPI or H2 blocker. If GERD is unresponsive to a PPI, then you may have to do esophageal manometry and pH studies and H. pylori testing. Or else H. pylori will continue to grow and will cause peptic ulcer disease. So H. pylori, you need to be tested for that if you're less than 60 with GERD, dyspepsia type symptoms. If unresponsive to PPIs, then you need to do manometry, pH study, or else you can lead to ulcer disease. If you do suspect H. pylori infection, treat empirically, but given antibiotic resistance, eradication should be confirmed, especially if there's treatment failure. If you suspect H. pylori, you want to treat empirically, but given antibiotic resistance, eradication should be confirmed, especially if there's treatment failure. You can do stool testing for the antigen or urea breath testing. And you can repeat this test 4 weeks after completion of therapy. H. pylori treatment depends on if you have a penicillin allergy or resistance. Standard treatment is triple treatment with a PPI, macrolide, penicillin. Modified is what? Modified with metronidazole if there's a penicillin allergy, versus quadruple therapy when there's macrolide allergy, metronidazole resistance, or treatment failure. And quadruple therapy is what? Acid suppression, metronidazole, bismuth, and tetracyclines. Esophagus disorders. If you have disordered and premature simultaneous contractions on manometry, or a corkscrew appearance, and that's diffuse esophageal spasm, and treatment of that is calcium channel blockers or nitrates, TCAs. If you have dysphagia of solids and liquids, that's something like achalasia. You want to get diffuse esophageal manometry, which shows high LES pressure and ability for the lower esophageal sphincter to relax. You have a beak sign, decreased peristalsis. Treatment for that is surgical dilatation, fundoplication. Second line is botulism, nitrates, calcium channel blockers. If you have dysphagia to solids only, then think of a stricture. You want to get an EGD. If you have pancreatic cysts, you need to do an endoscopic ultrasound for biopsy. 50% of pancreatic cysts are neoplastic. If they are malignant, you do a surgery. If they are benign, then you do serial CT scans to monitor. Cirrhosis can be compensated or decompensated, much like heart failure. Chief complaint of hematemesis and cirrhosis, you want to think variceal bleeds, which needs SBP prophylaxis with antibiotics, ceftriaxone for 7 days, and then Bactrim fluoroquinolones. Might need albumin. They have chief complaint of shortness of breath and cough and cirrhosis. You want to think of hepatic hydrothorax. They'll have to give lab values that show serum LDH with right-sided infusion. That's hepatic hydrothorax. And that will be transudative. If you have less than 0.5 pleural protein to serum protein, or less than 0.6 pleural LDH to serum LDH, or pleural LDH less than 2/3 normal serum, if you have cirrhosis with SBP, then treatment is paracentesis to show greater than 250 neutrophils, IV antibiotics, IV albumin, and if it's refractory to that, with uncontrolled variceal bleeds, then you need a wet procedure. Tips. If you have cirrhosis with chief complaint altered mental status with high ammonia, you have diagnosis of what? Metabolic encephalopathy. Treatment is what? To stop ammonia formation in the gut? Rifaximin. You can also give lactulose. If you have cirrhosis with a pleural effusion, treatment is to remove the inciting events, so drain the ascites with sodium restriction and diuretics. Then you want to do a thoracentesis. And only if things fail do you do a thoracoscopic repair or for a diaphragm defect. Other things that are transudative can be heart failure, kidney, cirrhosis of the liver, or constrictive pericarditis. If you have cirrhosis, you want to do maintenance. If you have cirrhosis, you want to do maintenance, looking for varices, right upper quadrant of the abdomen to look for cancer. And you have a 90-day mortality for end-stage liver disease based on the creatinine. Treatment for Zenkers is myotomy due to cricopharyngeal motor dysfunction. You want to visualize that with a barium swallow. If there's strictures, you want to be concerned for cancer, especially if there's dysphagia solid, so you want to get an endoscopy or barium. That's a solid choice if you have solid dysphagia. If you have diffuse esophageal spasm, scleroderma, achalasia, and dysphagia to solids and liquids, you want to do an endoscopy or barium swallow plus minus manometry. If you have caustic ingestion, you want to do endoscopy, get an x-ray. If you have GERD, you want to do a trial of PPIs. You might need to either switch or increase the dose, and you always want to do a confirmation of eradication testing with pH or stool antigen. And if you have a GERD plus alarm symptoms, you want to do an endoscopy. Alarm symptoms like unexplained anemia, age greater than 60 or less than 60. If you have things like B symptoms or unexplained anemia. Or if you have a history of familial cancers like familial adenomatous polyposis or Lynch syndrome. If you have someone with an ingestion of aspirin, alcohol, cocaine with hematemesis, you want to think of acute erosive gastropathy. If you have someone with hematemesis and vomiting, you can think of esophageal rupture. They'll have chest pain. If you have hematemesis with vomiting, you might have a GE junction tear, and you need to do upper endoscopy. If you have volvulus, usually it's in the sigmoid or cecum. It'll be an elderly person with chronic constipation. Complications of volvulus includes closed loop obstruction, for which you need surgery. After you see the dilated loop of colon on X-ray, could be a coffee bean sign. And if there's no rectal air, no flatulence, and bowel loops. If there's perforation or peritonitis, you want to do surgery. Otherwise, you can treat it with a flex sigmoid. If also concerned for toxic megacolon, you want to decompress. If there's hemorrhoids versus rectal prolapse will have a protruding mass. Could be treated with surgery. If there's hemorrhoids, you want to be conservative with management and banding. Acute diverticulitis, treated with antibiotics like Cipro and Metro. Diverticulosis will be seen on barium enema. IBD, PSC. PSC is intra and extrahepatic bile duct dilatations, seen with ulcerative colitis. PBC is just extra hepatic dilatation. You can have acute or chronic radiation proctitis. Signs and symptoms of that are fecal incontinence plus a history of radiation. There will be fibrosis and decreased compliance, which leads to incontinence. If you have an abscess, there will be fever, treated with antibiotics. And if there's puborectalis muscle or dysphagia, that'll have constipation because the pelvic floor muscles are not able to relax. So that means you're not able to poop enough versus proctitis is fecal incontinence and you poop too much. In the stomach, we can have gastric outlet obstructions, which on X-ray leads to a what bubble, a gastric bubble, which will need surgical repair. And if you've had gastric bypass surgery, you might have complications like vitamin C deficiency or the fat-soluble vitamins ADK or B12. If you have 3 gastric ulcers or more, you might be concerned for gastrinoma, so you get a gastrin level plus or minus secretin stimulation while they're off of PPIs. If you have pain that's worse on an empty stomach and relieved with foods, that could be secondary to an H. pylori's duodenal ulcer. You want to treat that with antibiotics and a PPI. Abdominal distension with a waxing, waning pain. That could be a bowel obstruction. Most likely, small bowel obstruction cause is what? Adhesions from prior surgeries. You'll see air fluid levels on small bowel x-ray. If you have uniform distension on x-ray, then that's ileus, versus differential air fluid levels, that'll be a small bowel obstruction. Ileus, you want to think of things like hypokalemia. If you have air fluid levels but no air in the rectum and no flatus, then you have a complete small bowel obstruction, and you need to use an NG tube to decompress and surgery. If you have pain, 10 out of 10, and your exam is unremarkable, you want to be concerned for acute mesenteric ischemia. They'll also have lactic acidosis, metabolic acidosis from the ischemia, leukocytosis. It could progress to infarction, and the gold standard for diagnosing that is an angiogram. You might have gallbladder issues where you have bile acid diarrhea. Treatment for that is what kind of stearamine? Cholestyramine. This often happens after surgery, and it's a secretory nocturnal poop. Things with the pancreas, so you might have pancreatitis. Worse when there's third spacing, so your BON will go up, hematocrit is increased, creatinine is increased. Hemorrhoids could be internal or external, below or above the dentate line. You can have rectal prolapse. You can have proctalgia fugax. It's not IBS, it's not IBD, there's no associated trigger. You might also have gonococcal proctitis with tenesmus and discharge. You want to get a PCR and treat it with antibiotics, ceftriaxone, doxycycline. Nocturnal post-chemo secretory diarrhea is treated with what? Stop the diarrhea with loperamide or diphenoxylate atropine, versus osmotic diarrhea, which usually occurs post-meal. Osmotic diarrhea, if you are NPO for a day or two, then it'll stop, but secretory will continue. If you have a post-antibiotic diarrhea with obstructed and dilated colon, you have concern for C. diff-induced toxic megacolon with leukocytosis, fevers. Cirrhosis, remember, he has increased estrogen, so you'll have stigmata of estrogen. You'll have splanchnic vasodilatation, portal hypertension. And portal hypertension has a high SAG, greater than 1.1, serum albumin minus acidic albumin. High SAG can also be CHF. Low SAG is things like cancer. If you do have portal hypertension, you have three types. You can have pre, intra, or post-hepatic categories. Pre-hepatic is things like portal vein thrombosis. Intrahepatic is things like hepatitis, schistosomiasis, infiltrative like sarcoid, PBC or PSC, or post-constrictive heart pericarditis, CHF, Budd-Chiari, IVC disease. If you have low SAG is something like an infection or cancer. If you just had surgery on your abdomen or have a fistula or a history of diabetes mellitus with greasy diarrhea, you might have what kind of overgrowth? Small intestinal bacterial overgrowth. Treatment for that is similar to hepatic encephalopathy with rifaximin, which can also be assisted with promotility agents like metoclopramide. Other things with gastroenteritis, you want to get a stool culture. And if you have post-GI infection with diarrhea and upset stomach, could be secondary to what kind of osmotic diarrhea? Could be lactulose intolerance. You want to get what kind of testing? Lactose breath hydrogen testing. Remember, with pancreatitis, it might be an obstruction, so you want to use ERCP to remove the obstruction. If hemorrhoids are getting you down and they're refractory or thrombosed, then you need to do surgery. If you have steatorrhea, that could be secondary to pancreatitis, cystic fibrosis, biliary disease, giardia, Crohn's, small intestinal bowel overgrowth, small intestinal bacterial overgrowth, treated with rifaximin, other things, infection, HIV, celiac disease, Whipple's, Zollinger-Ellison Right upper quadrant pain, you might consider appendicitis as well as for right upper quadrant pain, you might want to consider appendicitis or ovarian torsion, and especially appendicitis in pregnancy. Could be atypical because of displacement of the uterus. If someone comes with alcohol use, a history of gallstones, triglyceridemia on lipid panel, you want to get an ultrasound, CT abdomen, pelvis, lipase to diagnose your acute pancreatitis. You want to do surgery if there's any necrosis, if there's a pseudocyst or ARDS, DIC, or pleural effusion. Otherwise, treat conservatively NPO, NG2 for suction, antibiotics, plus or minus ERCP if there's an obstructing dilatation due to a stone, and plus or minus cholecystectomy if there are gallstones in the bile duct and the gallbladder. If someone comes with colicky right upper quadrant pain and gallstones on ultrasound, you might want to do an MRCP or diagnostic and therapeutic ERCP. Treatment is supportive, changing the diet, and you might need to do surgery if there's symptoms or cancer risk like porcelain gallbladder. And if there's any post-surgery diarrhea, you want to treat the biliary diarrhea with cholestyramine. If you're coming in with left lower quadrant abdominal pain, you want to get a CT abdomen pelvis with contrast to see the thickened fat stranding, intestinal wall edema, and diagnose acute diverticulitis. Treatment for that is antibiotics, Cipro, metronidazole, keep an NPO, fluids, and if there's any complications like perforation, hemodynamic instability, or abscess, you want to drain those, do surgery, and defer colonoscopy. If you have someone with diarrhea, failure to gain weight, steatorrhea, and they didn't just have their gallbladder taken out, and they do have autoimmune disease history, you might need to consider that they have something like celiacs. You want to get an anti-TTG antibodies, get gluten-free. You want to check their hemoglobin, see their ferritin is low, TIBC is high. They have anemia of chronic microcytic anemia, could get EATL lymphoma. And if there's a kid coming in with bilious vomiting, or a constipated adult with non-bilious vomiting, you might consider something like volvulus, which you'll see on abdominal x-ray. If there's no gas pattern, then you want to do an upper GI series. In pediatrics, they'll have what kind of rotation? Malrotation. And if they have an abdominal gas pattern, they might need a barium enema. And if that doesn't work for volvulus, then they might need to detorse with a flex sigmoid. And if that doesn't work, then they might need surgery. If you're coming in with chest pain and regurgitating food, then you want to consider GERD. If there are no red flags, then you can choose to treat conservatively with lifestyle changes, PPIs, H2 blockers. You want to do an EGD and upper endoscopy if there are any red flag symptoms or if they're greater than 60, and you want to treat the H. pylori and test with eradication with stool antigen or breath test. If someone's coming in with diarrhea due to the C. diff, you do PO-VANC. If it's cholera, you want to treat with what? Doxy. And if you come in with Giardia, you want to treat with what? Metronidazole. Again, those red flags for GERD is GI bleeds greater than 60. If you have inflammatory bowel disease, nocturnal diarrhea, weight loss, or family history of cancer or unexplained anemia. If you come in with pain with feeding, you could consider cholecystitis, but you might also want to consider peptic ulcer disease, most commonly caused by H. pylori. So just go ahead and treat with triple therapy, PPIs, and possibly endoscopy. Most common causes of peptic ulcer disease is H. pylori, but then also you want to consider someone's been popping NSAIDs for forever, cancers, secreting gastrin, things like dumping syndrome, or chronic pancreatitis. Other causes of diarrhea could be microscopic colitis. You want to stop the NSAIDs and the smoking, treat with budesonide. That could also help with any peptic ulcer disease. What kind of scan do you get if cholecystitis ultrasound is equivocal? You want to do a HIDA scan. Cholecystectomy is usually all you need, but if there are complications like calculus, splenic abscess, perforated cholangitis. Then you want to do a percutaneous cholecystostomy tube. This can also, cholecystitis can also lead to complications like emphysematous ileus versus gallstone mechanical obstruction ileus, which can be treated with ERCP. Cirrhosis, if someone comes in, you want to rule out causes of cirrhosis like viruses, alpha-1 antitrypsin, anti-smooth muscle, anti-mitochondrial, and get ferritin, 24-hour copper, and you want to get the following treatments. So you want to get an ultrasound, you want to restrict sodium, alcohol, and smoking. You want to give antibiotics with variceal bleeds for concern for SBP. You want to get vaccinations to get against those viruses like the hepatitis. You might want to do screening like ultrasounds, upper endoscopies, looking for varices, hepatocellular carcinoma, and hepatic hydrothorax, which will present with shortness of breath, more commonly on the right. And this will have also treatment for hepatic encephalopathy, like lactulose. And you want to screen for hepatocellular carcinoma with AFP. And again, the hepatic hydrothorax will be a transudative Leitz criteria where the pleural is less than what's in the serum, as opposed to exudative where everything is higher in the pleural. Again, the most common cause of acute abdomen is appendicitis. It's a clinical diagnosis. You might need to do CT or ultrasound, but always get the beta-HCG before doing the CT. Differential diagnosis for appendicitis includes a psoas abscess. Usually there'll have been a preceding infection. You'll see the abscess on CT. Other things, appendicitis, things like renal stones or OB-GYN like torsion. If you have someone with liver disease, diabetes, and hypogonadism, then you want to consider hemochromatosis. Their ferritin will be high. They'll have a mutation on chromosome 6 in the HFE. Treatment is phlebotomy and chelation. You also want to get an MRI of the liver to look for any cancer. And there's complications with infections and hemochromatosis, specifically iron-loving bugs like Vibrio vulnificus. If you have someone coming in with vomiting and chest pain and crepitus, you want to think of a ruptured esophagus. Complications include mediastinitis, infections, and pleural effusions. To diagnose this rupture in the esophagus, you want to use gastrographin contrast. You want to take them to the ICU and do surgery. If you have someone coming in with altered mental status with liver disease, the risk factors are infection or stressors, GI bleeds, TIPS procedure, hepatocellular carcinoma, electrolyte imbalances, and medications. These all lead to a decrease in ammonia clearance. So this doesn't have to necessarily be in cirrhosis, but it's commonly a hepatic encephalopathy due to cirrhosis. The first line treatment is again lactulose and rifaximin and repleting the electrolytes. You want to do liver labs and a head CT to rule out any other causes of altered mental status. The differential diagnosis of altered mental status could also be DKA, mass, or uremia. With ulcerative colitis, again, IBD, you want to get a follow-up colonoscopy 10 years after the diagnosis, and then every 3 years after that. Treatment for that medically is going to be 5-ASA, steroids, and iron. Complications of UC include toxic megacolon, PSC, and colon cancer. That's why you get the colonoscopies. You can also get ulcerative colitis, osteoporosis, and eventually you might need maintenance therapy in addition to the acute UC flares. Acute UC flares, steroids, 5-ASA. UC maintenance include DMARDs like infliximab, azathioprine, or TNF-alpha inhibitors. You may also need surgery. If someone's coming in with nausea, vomiting, abdominal distension, you want to think of a small bowel obstruction. If someone doesn't have flatus or passing any gas, and then you have concern for complete small bowel obstruction with peritoneal signs or any absent rectal air on x-rays, so then you want to go and get surgery. Otherwise, the x-ray will just show free air. The CT may show any masses, and lactic acid might show any necrosis from the ischemia. Treatment is NPO, NG tube decompression fluids for partial SPO, and complete SPO surgery. If there's any peritoneal signs with an abdominal exam, you want to get an x-ray to rule out free air, plus or minus a CT, and a fast exam, especially if they're in shock. You want to be considering sepsis or an abscess. And if someone's coming in with dysphagia, you want to get something like manometry, esophageal manometry, to show an increased lower esophageal sphincter tone. Dysphagia of solids and liquids, that'll be something like achalasia. Treatment for that is balloon dilatation, fundoplication. There's a theme in GI obstructions, so if there's any gallstones in a bile duct, then that could lead to an obstruction and a retrograde ascending cholangitis. You'll visualize this in ultrasound, MRCP, but it's also clinical with lab values. You'll have increased bilirubin, LFTs, transaminitis, jaundice, right upper quadrant pain, fever. Treatment is antibiotics and remove the triggering obstruction. So you want to do ERCP or drainage, and then later on a cholecystectomy to remove the source of the obstruction, which was ultimately the gallbladder. If you have a lower GI bleed, you want to consider first if they're stable or unstable. Stable hematochezia requires an anoscopy and colonoscopy to look for hemorrhoids, prolapse, or any other types of colon etiology. And if they have unstable hematochezia, then you want to resuscitate them and do an upper EGD, as well as possibly angiography plus or minus surgery. If you have someone who's elderly and who came in with abdominal pain, then they had any sort of low flow state, you want to consider ischemic colitis. Diagnostic gold standard for that is angiography plus or minus colonoscopy. Treatment for that is supportive, but watch for peritonitis, which will require surgery. If someone came in with severe abdominal pain with intestinal type angina, and they have vascular risk factors with lactic acidosis on CBC and CMP, and GI bleeding, you want to consider mesenteric ischemia. This can be acute or chronic. Gold standard is angiography. If it's occlusive, they might need surgery. And if it's non-occlusive, they might need fluids and anticoagulation, vasodilatation. If someone comes in with abdominal pain, you might want to consider acute hepatitis. This could be due to viral etiology, alcohol, fatty liver disease, non-alcoholic fatty liver disease. Confirm this with ultrasounds, CBC, transaminitis, hepatitis panel. You want to treat the cause. If you have someone who comes in with recurrent episodes of pancreatitis-like episodes, they might have history of malabsorption, vitamins A, D, osteoporosis, E or K, with bleeding issues, or new onset elderly diabetes. You want to get a CT scan to look for chronic pancreatitis, or if there's maybe possibly a mass, to rule out cancer causing an obstruction. In chronic pancreatitis, do not rely on the lipase, and you want to get possibly an MRCP or ERCP if there's any obstruction causing the chronic pancreatitis. Also change the lifestyle, acid suppression, enzymes to help with the malabsorption, plus or minus surgery if there's any obstruction. Liver failure. If someone comes in with liver failure, they could have coma, hepatic encephalopathy, pain, bleeding. Could be most commonly from DILI or drug-induced liver injury, toxic drug ingestion. They'll have transaminitis in the thousands. They'll on ultrasound, CT abdomen pelvis. You also want to get a head CT to rule out any other causes. You want to get fresh frozen plasma, treat the trigger, and decrease intracranial pressure. If someone's a female coming in with increased bilirubin, alk phos, transaminitis, increased GGT, you're thinking biliary source, something like primary biliary cholangitis or cirrhosis. This is associated with xanthomatous skin findings, anti-mitochondrial, mito because just in the ladies, as well as extra hepatic bile duct dilatation, pruritus. You want to confirm this with biopsy. Could you get an ultrasound, ERCP, see the dilatation, and you want to treat it with vaccines against the hepatitis groups. You want to reduce alcohol. You want to reduce the biliary acid with ursodeoxy acid, cholestyramines, and eventually transplant. If you have someone coming in with hematemesis, retching, you want to consider a GE junction tear, Mallory-Weiss. You want to stabilize them, resuscitate. You want to give them fluids, and get an endoscopy for Mallory-Weiss GE junction tear. A differential includes rupture, for which you need gastrografin or aspirin medication-induced esophagitis, or variceal bleeds from cirrhosis. If you have someone with upper GI bleeds, you want to stabilize them with fluids and blood if need be, make them NPO, acid suppression, and then do an endoscopy. They might need octreotide if there's cirrhosis and splanchnic vasodilation, antibiotics to ward off SBP. And if there is an ulcer, then you can do local epinephrine injections. And if there's varices, then you want to do banding or sclerotherapy and secondary prevention with beta blockers. If someone's coming in with liver disease and rising creatinine, you want to consider hepatorenal syndrome, secondary splanchnic vasodilatation, and decreased renal perfusion blood pressure due to a decrease in effective arterial blood flow. Treatment for this for HRS is what? Vasopressors, norepinephrine. You might also want to do albumin. You also can do midodrine or octreotide. Again, if someone has esophageal varices, you want to do stabilization, fluid resuscitate if need be, blood, and then do an endoscopy. Primary prevention for variceal bleeds is beta blockers and ligation. And then secondary prevention also includes beta blockers, but you can also add nitrates. If there's an acute bleed, again, stabilize them, IV fluids, antibiotics for SBP, octreotide for the dilatation of the splanchnic vessels. And if you have refractory bleeds from the varices, you want to do a TIPS procedure. But watch out with that, you can get hepatic encephalopathy. And if you have pancreatic pseudocysts, get a CT. Don't rely on the lipase. You might need to do obstruction, removing MRCP, ERCP, get a biopsy to rule out cancer. If you have abdominal pain that's related to food, it could be gastritis. You want to treat that empirically for H. pylori and do a breath or antigen stool testing to confirm about 4 weeks later. If you have alcoholic liver disease, you want to treat that with what? Steroids, nutrition changes, and stopping alcohol, or else you might get cirrhosis. If you have cysts on the liver, could be buggles like hydatid cysts, which you want to treat with what kind of antiparasitics? Albendazole, plus or minus resection if it's big enough. You'll see eggshell calcification cysts, increased what on a CBC differential, eosinophils. And this is different from a simple cyst or a cyst adenoma, carcinoma. And if you have someone with abdominal pain that looks like they're about to die because they have shock, low hemoglobin, hypotension, think something vascular has ruptured and is bleeding. And if they have any of the following, like pancreatitis, history, lupus, EBV, lymphoma, anticoagulation on board in terms of medicines, you want to think something vascular like a spleen. If spleen has ruptured, you'll have abdominal pain and hemodynamic instability. If they're unstable, you want to do an XLAP. If they are stable, you want to do a CT to embolize. And you'll see this on ultrasound fast exam. The cousin of PBC is PSC. You can also treat this with ursodeoxy, cholic acid, cholestyramine, but you can also do ballooning and stenting. Complications of this include ascending cholangitis. Remember the fever, quadrant pain, triad. Complications of PSC also include bile stasis, which leads to steatorrhea, and also ADEC insufficiency. It's also associated with ulcerative colitis. Remember, metoclopramide is associated with extrapyramidal signs due to its dopamine antagonism. It's being used to treat gastroparesis, but don't use if someone has Parkinson's disease or a small bowel obstruction. If someone's coming in with painless rectal bleeding, could consider internal hemorrhoids or this thing that you can see in older people on CT or colonoscopy. Diverticulosis. Treatment for diverticulosis is a high-fiber diet, IV fluids, colonoscopy with possibly cauterizing the bleed, and angiography. Now, if you have inflammation of a diverticulosis, that becomes diverticulitis, and you need bowel rest and antibiotics. Someone might have bleeds and aortic stenosis, and that's a triad of angiodysplasia, Hyde syndrome. You could have Whipple disease, portal hypertension with a high SAG, postprandial diarrhea, again, lactose intolerance versus something secretory. Back down in the butt department, you have anal fissures, abscesses, hemorrhoids, and prolapse. You can differentiate these because an abscess is a fluctuant mass. You want to treat anal fissures conservatively with topical lidocaine, calcium channel blockers, nitrates. You have someone who comes in with a large abdomen, distended, shifting dullness. It's ascites. You want to get a paracentesis. Analyze the cells in culture for greater than 250 neutrophils. You want to treat them with diuretics to get the fluid off of them. Might even do a therapeutic para. Antibiotics for SBP prophylaxis. You might need to add albumin if you take off enough fluid. And complications include SVP or hepatorenal syndrome. And again, if you have hepatorenal syndrome, you might need to squeeze down on the splanchnics with vasopressors or help the effective arterial blood flow, and possibly even give albumin. If someone had abdominal gastric surgery and they have post-surgical diarrhea, that might be dumping syndrome. So diarrhea, dumping syndrome, you want to change their diet. That's first-line treatment. You might even be due to secondary to pyloric sphincter dysfunction. You'll see it on upper GI. Going back to liver disease, if someone has a high BMI, transaminitis, and a hyperechoic liver on ultrasound with no history of alcohol use or other causes, you might consider non-alcoholic fatty liver disease. That's associated with metabolic syndrome, diabetes, hypercholesterolemia. Treatment is lifestyle management. And if you have a BMI greater than 35, you could be a candidate for this type of surgery, bariatric surgery. Here's a GI-PEDS connection. If you have breast milk jaundice, the treatment is to feed them more and add formula. And if you have breastfeeding failure, they'll be dehydrated. If you have a baby with meconium ileus, treatment for that is a hyperosmolar enema and gastrographin, possibly surgery. And if you have a newborn with bilious emesis, the workup for that includes to stop feeds, do an NG tube, give feeds by IV, and do an X-ray. You might need to do a contrast enema or an upper GI series or surgery. And the differential for that includes, complications of that include necrosis, volvulus, meconium ileus, duodenal bubble. If you have someone with increased alk phos, check the GGT to see if it's biliary. If it's high, then you want to get a right upper quadrant ultrasound. If you see any dilated ducts, you want to get an ERCP. And if you get an anti-mitochondrial antibody assay, positive AMA, you want to get a biopsy for the PBC. If you have abdominal pain, chronic malabsorption, and ultrasound shows a dilated common bile duct with cancer signs like weight loss, you want to get a CT to look at the pancreas. If you do an ultrasound and you see a normal common bile duct, but dilated intrahepatic ducts, then you want to consider this kind of cancer. Cholangiocarcinoma can have dilated intrahepatic ducts. And both pancreatic and cholangiocarcinoma, cholangiosarcoma, can have increased CA19-9. And if you did an ultrasound and there was absence of a gallbladder, that's called biliary atresia. They'll have high direct bilirubin and high GGT. You might consider this in pediatrics. Biliary atresia needs a Kasai procedure. And if you have abdominal pain with hemodynamic loss, like low blood pressure, low hemoglobin, and they had Epstein-Barr virus, you might consider splenic rupture, especially if they have what kind of shoulder pain? Left shoulder pain, which is called Kerr sign. Again, this could be non-traumatic splenic rupture from something like having lymphoma related to the EBV, cirrhosis, pancreatitis, lupus, anticoagulation. This is especially common in elderly. They'll have left-sided abdominal pain, so you might think of diverticulitis, but consider the spleen. And they might have syncope because of the blood loss, and they might be on blood thinners for their AFib, or they had a history of cancer, and eventually the congestion can cause splenomegaly and rupture leading to shock. The elderly might also have lower bowel obstructions from Ogilvy's, which needs decompression. If you have someone with small bowel obstruction, you'll have on imaging narrowing and air fluid levels. However, if you have air throughout the bowel and there's appearing to be an obstruction, it could be ileus. Ileus will have a constant pain versus small bowel obstruction will be intermittent pain because your colonic intestinal muscles are still active in SBO. They're trying to intermittently squeeze and peristall, so there's intermittent pain. Versus ileus, your colonic intestinal walls are shot for some reason, so there's constant pain. And on X-ray, CT, you'll see air throughout the bowel. Treatment is to discontinue anything that's anti-motility. You want to check your potassium for any hypokalemia. You want to check TSH for any hypothyroidism. You want to check an A1C for any autonomic nervous system dysfunction, and any medications. So again, anything that's anti-motility. Diagnostic test of choice for mesenteric ischemia is CTA. If you have diverticulosis, you want to give high fiber and hydrate. If you have diverticulitis, you want to do NPO, NG-tube, antibiotics, colonoscopy, unless there's something complicating it like a stricture, abscess, or perforation. Small bowel obstructions, we know those are caused by adhesions, but also hernias or cancer, age, ileus, and large bowel obstructions can be cancer, inflammatory bowel disease, Ogilvy's, or ileus. If you have cancer, you want to do biopsy and MET staging, get a chest x-ray, LFTs, CT, abdomen, pelvis. If you have ischemic colitis, it could be a stroke of the intestines due to a small mesenteric artery watershed. They'll have bloody diarrhea with intestinal angina. You want to get a CT with contrast. Again, with acute cholangitis, you want to do antibiotics, IV fluids, ERCP. If there's cholangitis, there might be acalculous cholangitis. There's a subtype of that, which you want to treat with a percutaneous tube. And if there's choledocholithiasis, you want to do an ERCP. Hepatitis can be acute or chronic. Acute can be the ABCDEs of viruses, drugs, DILI, or shock. Or if you're pregnant, you might have hepatitis E. And if you have chronic hepatitis, you want to consider alcohol, HCV, autoimmune, or metabolic. So if it's something like HCV, you want to start sofosbuvir, cimeprevir. If you have autoimmune hepatitis, you want to get the anti-smooth muscle, cytosol, or microsomal. If you have metabolic concerns, you get a 24-hour copper for Wilson's. Treat that with chelation, zinc, change in diet. If there's hemochromatosis, you want to do phlebotomy or chelation. And there are different types of pancreatic tumors, right? So there's an insulinoma, which has a high C-peptide. You'll see that on ultrasound, CT, and MRI. And you might also get selective arterial calcium stimulation. A VIPoma with watery diarrhea and hypokalemia, you want to see on CT. And again, elderly patient who suddenly develops diabetes, you also want to consider pancreatic cancer. Hepatitis HBV and HCV can lead to hepatic cellular carcinoma. It can also be a downside effect of cirrhosis or PBC. You want to do orthotopic treatment if there's small and few, and sorafenib if there's metastasis. PBC you want to treat with ursocholic acid. PSC you want to treat with an ERCP stenting transplant. And just to cross over into the GU world, so there's hypospadia, which needs a urology consult. You can have Wagner syndrome, which is Wilms tumor, growth, retardation. You might also have hematuria. Pregnancy will worsen diabetic nephropathy, as well as hypothyroidism, so increase the levothyroxine. If there's crepitus in the perineum, consider 4 years gangrene and do surgery. So a kid had Kawasaki's, get an echo. HIV related to FSGS nephropathy, consider that versus secondary membranous from hepatitis B or C viruses. If someone has back pain with a scrotal nodule, you might likely consider cancer. Get an ultrasound. You'll see a solid hypoechoic lesion, and the treatment is surgery. The most common cause of that is germ cell tumors. You will see increased AFP, beta HCG, tumor markers. The germ cell tumor could be seminoma or non-seminoma. Retroperitoneal lymphadenopathy with pulmonary nodules. You want to consider testicular cancer metastasis. Get an ultrasound for that. In the same neighborhood, prostatitis. You want to treat with bacteria control with Bactrim or quinolones. Penile fractures you want to treat with surgery plus or minus urethography. Torsion you want to treat with, we want to see on Doppler ultrasound and the orthopexy. Anterior versus posterior urethral injury. Anterior versus posterior dome of the bladder injury. How do you tell the difference between prostatitis and epididymitis? Epididymitis will have focal tenderness, often caused by GC chlamydia. Prostatitis will have plus minus symptoms of the prostate and also has recurrent infections. You might have chronic prostatitis due to an infection or non-infectious chronic prostatitis, pelvic pain. And then you also might have urethritis, which will have discharge. So that's how you tell the difference between those three. Remember, prostatitis and epididymitis both can have painful ejaculations, so you can't really use that to differentiate. Abdominal pain that isn't GI related could be herpes zoster. Remember, that can have nocturnal abdominal pain, history of breast cancer, maybe immunosuppression, pain out of proportion, but it's not acute abdomen and it's not acute mesenteric ischemia. So consider herpes zoster. If you have sudden acute abdominal pain, nausea, vomiting, back pain, binging alcohol, you might consider pancreatitis. Get an amylase lipase, CT imaging if it's unclear. And if you had acute liver failure secondary to Tylenol, you need to get a liver transplant. 50% mortality if you don't. Rifaximin is treatment for both hepatic encephalopathy and small intestine bacterial overgrowth. Watery diarrhea from microscopic colitis, and any nocturnal diarrhea is a red flag. Again, small intestine bacterial overgrowth or SIBO, change the diet because usually you just had diarrhea after some sort of gastric surgery, crampy abdominal pain, diarrhea. You want to diagnose this with a carbohydrate breath test. This could be, again, due to uncontrolled diabetes or even opioid use. Diagnosis is a biopsy of your jejunal aspirate. Treatment, again, is rifaximin. You might also have decrease in B12. Watch out for subacute combined degeneration. You could have other things like fecal incontinence and constipation or diarrhea. Rule out an impaction if you have both constipation and diarrhea with an exam and a KUB. especially if they're on opioids. So opioids can cause both SIBO and fecal incontinence. If you have panlobular white blood cells and cell necrosis on biopsy for a liver, you want to consider DILI, dose-dependent and dose-independent or idiosyncratic. For example, anti-HIV medications are dose-independent sources of DILI. IV drug use, think hepatitis C and cirrhosis. Could also have TB with RIPE therapy, colonoscopy, screening 10 years before families, starting at 40 or sooner. Anemia with NSAIDs, you want to consider gastric ulcers. Cirrhosis treatment is Lasix, spironolactone, salt restrictions, stopping alcohol. That actually reduces the pressure and reduces the mortality. If you have decompensated cirrhosis, you want to avoid ACE inhibitors, avoid NSAIDs. People with cirrhosis have a low effective arterial blood flow. Therefore, your antidiuretic hormone is released, and fluid is retained. So don't further lower the effective arterial blood volume with RAS blockers or PRILs or NSAIDs, because NSAIDs stop PGEs, prostaglandins, which vasodilate the afferent arteriole. So if your NSAIDs are blocking those, then NSAIDs cause reduced GFR. If you have GERD-like pain radiating to the back, especially with hot and cold food relieved by calcium channel blockers and nitrates, you could consider that it's anginal pain from the heart, or it could be diffuse esophageal spasm. You could also have pill esophagitis, which has sudden onset GERD-type pain. You want to treat HSV with acyclovir, and linear ulcers in the esophagus could be CMV. So that will be also antiviral treatment. Von Willebrand's disease, angiodysplasia, renal disease, aortic stenosis. That can also be a syndrome causing painless GI bleed, so you get an endoscopy to do cauterization on the AV vessel malformations. If you have dysphagia, choking sensation, coughing, regurgitating, that's oropharyngeal, and you want to get a barium swallow to assess the upper pharynx, the oropharynx. Versus if you have esophageal dysphagia, where you're not able to even pass fluids or liquids, you want to get EGD and barium swallow. And if you have progressive dysphagia, then that's a concern. You want to get, if you have cancer risk, you want to get barium swallow. And if there's no cancer risk, you want to do an endoscopy with biopsy. If you have a globus sensation, that's worse with anxiety and producing a lot of saliva, that's globus sensation. Gastritis can be acute or chronic. Acute could be from something like a stress ulcer or CNS injury. More often, you have chronic gastritis being caused most of the time by H. pylori. 90% of the cases, you'll get an antigen breath test, which is a test of choice. You also want to do eradication tests. But this also could be peptic ulcer disease or a maltoma. And if you have chronic autoimmune gastritis, that's could be autoimmune, causing pernicious anemia. If you have pernicious anemia and B12 deficiency, you'll have elevations in both homocysteine and methylmalonic acid, so high HM and high MMA. Talking about the hepatitis panel, hepatitis B, if it's isolated, anti-hepatitis B positive, then you want to get IgM antibodies for the core, because it could be positive IgM against the core, meaning you're in the window of an acute HPV infection. If you have negative IgM core, then you have chronic HPV with liver disease. Or if you have negative IgM core, then maybe it's because you had a recovered HPV years ago. Hepatitis C, you need vaccines against both H and A to safely take less than 2 grams of acetaminophen. HCV is transmitted by IV drug use, so barrier protection for sex is required. You want to screen for fibrosis, renal disease, cryoglobulinemia, alcohol and substance use cessation. Splenic vein thrombosis can occur after pancreatitis, causing isolated gastric varices. Chronic splenic vein thrombosis can cause portal hypertension and congestion, leading to a high SAG. Vitamins B and C are water soluble. You can have stomatitis and angular chelosis with B2 riboflavin deficiency. You can have wet beriberi dilated cardiomyopathy with polyneuropathy and Wernicke's-Korsakoff with B1 thiamine deficiency. Think Hobbs. Pellagra, photosensitivity, diarrhea, and dementia with B3 niacin deficiency. ADEC, you can have bleeding issues and bone loss. Autoimmune diseases, think of AMA and anti-mitochondrial with PBC. Elevated GGT, alk-phos, bilirubin, you have cholestasis treated with ursocholic acid. Confirm with biopsy. Again, treat with ursodeoxycholic acid, which slows it down. They might also have xanthelasma, xanthomas, and bone loss secondary to the ADEC fat malabsorption. Alpha-1 antitrypsin disease is cirrhosis with emphysema and family history. Anti-smooth muscle is autoimmune hepatitis with a high AST, ALT, but normal biliary alk-phos and GGT. Smooth muscle, autoimmune hepatitis. If you have high ferritin, transferrin, liver disease, diabetes, you might have hemochromatosis, treat with chelation. Ulcerative colitis, again, associated with toxic megacolon and colon cancer. You want to do the screens 10 and 3. Dysphagia, again, dysphagia can be upper or lower. Upper oropharyngeal, you have trouble initiating swallowing, you have drooling and coughing, might have referred ear pain. Lower type of dysphagia is more esophageal. It's food sticking in the chest sensation and chest pain. If you have dysphagia on the outset for both solids and liquids, you want to consider something neuromuscular. You want to get a barium swallow or manometry for motility disorder. Versus if you have dysphagia that starts out for solids and then progresses to liquids, you want to think of something like mechanical. So then you want to, be concerned for something like strictures or cancer. If you want to diagnose the oropharyngeal dysphagia or upper dysphagia, then you want to get a nasopharyngeal laryngoscopy. If you want to diagnose esophageal dysphagia, you want to get a barium swallow and EGD if it's lower esophagus. If you have delayed gastric emptying and you have a concern for mechanical causes, you want to get an upper EGD to look at things. But if you have delayed gastric emptying, but you're not concerned for an obstruction, you want to think something like diabetes, gastroparesis, or nerve injury, or anticholinergics. If you have nausea, is it localized or isolated? If you can localize the nausea to the stomach, you want to get an EGD to look for something mechanical like strictures. And if it's isolated and it severely fluctuates, you want to consider a partial GI obstruction. And if it's isolated and the severity is constant, so it's there, nausea all the time, it's maybe not something that is peristalsing, but rather it's something that's constantly there, like maybe constant intracranial pressure elevation, maybe a complete GI obstruction, so there's no peristalsis whatsoever, or maybe something non-GI like cardiac ACS, or maybe there's something wrong in the blood. So something like with your electrolytes, having low electrolytes, low salt, low calcium. Maybe you have endocrine adrenal insufficiency, some other endocrinopathies like pheochromocytoma, MEN1, MEN2A, MEN2B, hyperthyroidism, beta HCG, chemotherapy or toxins. Also in the GI system, you want to consider a constellation of symptoms with GI and Raynaud's and pulmonary hypertension. You want to think of sclerosis, concern for systemic sclerosis in the lungs or in the kidneys. You could diagnose it in the lungs with PFTs. If you have interstitial lung disease, your PFTs show a decline in your total lung capacity and your diffusion capacity, versus pulmonary hypertension, which preserves your total lung capacity, but you do have a big drop in your DLCO. So the difference is the lung capacity between ILD and pulmonary hypertension. Most common cause of ascites is cirrhosis. That's a high SAG. You might also have CHF, which is also a high SAG, versus something like exudative, like cancer. That would be a low SAG. Remember, SAG is serum albumin minus the acidic albumin. If it's higher than 1.1, you want to consider something like portal hypertension or non-portal hypertension. High SAG is usually portal hypertension. If there isn't any portal hypertension, then you might consider something like yeast urine or a chyle or peritoneal dialysis. But usually it's portal hypertension causing high SAG. Then you have the three types: pre, intra, and post-hepatic. If it's low SAG, less than 1.1, then you want to consider something like an infection, autoimmune, or cancer, or nephrotic. The worst combination is you have high protein and low SAG. So, if you have GI bleeds, remember most things in the lower GI bleed are bright red blood, but 15% of hematochezia can be upper GI bleed. Upper GI bleeds will have lab findings high BUN and creatinine. They'll be most likely to cause hemodynamic instability, orthostatic hypotension, passing large volumes of bloody stool, especially acute bleeds that don't have time to become dark, tarry, and black. Risk factors for GI bleeds are NSAIDs. Treatment is diagnostic and therapeutic with EGDs. If you might need to give platelets if they're less than this number, if they're bleeding, or less than this number if they're non-bleeding. Less than 20 if they're not bleeding, and less than 50 if they are bleeding, or if they're taking something like antiplatelets like DAP therapy. Transfused if less than 7, or 8 if acute ACS, CAD. Lower GI bleeds. Never do a colonoscopy on someone who is unstable, but a lower GI bleed does need a colonoscopy. If you have secondary to penetrating eroded small arteries in outpouches, that's diverticular bleed, and that's usually painless hematochezia. Diagnosed colonoscopy or tagged RBCs. If you have secondary to perforated diverticulum that presents with fever, abdominal pain, nausea, vomiting. Secondary to AV malformations like colonic angiodysplasia, usually associated with von Willebrand's disease, aortic stenosis, ESRD. Secondary to colon cancer, ulceration will be weight loss, change in diet habits, or change in bowel habits rather, and pain. All right, miscellaneous facts. Greater than 60 years old, do an endoscopy for indigestion. Post-GI surgery diarrhea, consider bile salt diarrhea, especially after a cholecystectomy or ileal resection. Treatment is cholestyramine. Vipioma diarrhea, treatment is somatostatin analog like octreotide. Steatorrhea from pancreatic insufficiency is treated with enzyme replacement. You want to investigate peripheral neuropathy, tachycardia, hyponatremia, worse after phenytoin. You want to consider acute intermittent porphyria. Treatment for oral candida is nystatin. Only if you fail that do you do fluconazole. If you have a stress ulcer, give PPIs. Treat giardia with tinidazole or nitazoxanide, or metronidazole if they're in kids, or parabamycin in pregnancy. Treat non-typhoidal inflammatory diarrhea. GI pathology: collagen deposition in the colon, Collagenous colitis will have watery diarrhea. That's secretory. Bacterial growth in the jejunal aspirated culture is small intestine bacterial overgrowth treated with rifaximin. Normal mucosal architecture with no inflammation with diarrhea. Consider IBS, maybe even giardiasis. Transmural inflammation with lymphocytic infiltrate. Think of Crohn's. Microabscesses with neutrophils. Think ulcerative colitis. If you have no polyps or they're less than 10 millimeters, you want to repeat colonoscopy in 10 years. If you had a polyp greater than a centimeter, you want to repeat it in 3 to 5 years. If you had a couple of tubular adenomas, less than 10 centimeters, less than 10 millimeters, repeat in 7 years. You had 3 to 4 tubular adenomas, less than a centimeter, just subtract the 4 from 7 years and you get 3 years screening. And if you had 5 to 10 TAs, less than a centimeter, or any tubular adenoma greater than a centimeter, or any tubulovillous, villous adenoma, or high-grade adenoma, then repeat in 3 years. If you had more than 10 adenomas of any kind, you want to repeat in a year. And if you had greater than 2 centimeters removed by piecemeal excision, you want to repeat in 6 months. Remember, Crohn's is any part of the GI affecting from the mouth to anus, but 80% of distal ileum small bowel involvement. These Crohn's has skip lesions. It's not continuous. It will have granulation tissue with collagen in the capillaries and anti-ASCA antibodies. The myofibroblasts will cause contractions, which leads to the cobblestoning. Its full thickness has skip lesions, fistulas, and fissures. Aphthous mouth ulcers has increased risk of colon cancer if it's in the colon. Malabsorption, string sign on X-ray. Small bowel obstruction of hyperresonant high-pitched sounds like the rocks plunking. The most common site is the terminal ileum inflammation. It'll have macrophages, granulomas. Right lower quadrant pain reflects the ileum and cecum inflammation. It'll have malabsorption of fat and fat-soluble vitamins, ADEC, bile salts treated with uracil acid. Weight loss and creeping fat on gross dissection as the fat is pulled closer to the serosa. It's transmural, non-caseating granuloma, bowel wall inflammation with bowel obstruction, strictures, fistulas, anal fissures, abscesses, white aphthous ulcers in the mouth. It can form calcium oxalate and uric acid stones, B12 deficiency, which takes years to develop, the SCD ataxia, dorsal column, medial meniscus, corticospinal weakness. And if you have ulcerative colitis, that is always involving the rectum, spreads proximally and continuously. The loss of haustra without projections leads to a lead pipe image, and its antibody relationship is P-ANCA, or perinuclear anti-neutrophil cytoplasmic antibodies. Its erosion is the mucosa and submucosa only, causes these friable pseudopolyps appearance. Also, ulcerative colitis has abscesses in the crypts with inflammatory infiltrates with neutrophils. It has left-sided abdominal pain because of the distal colon and rectum involvement. It can cause bloody diarrhea. Interestingly enough, it has lower incidence with nicotine use, but it has complications like fulminant colitis, toxic megacolon, leading to perforation, peritonitis. Also increased risk of colorectal cancer, the adenocarcinoma, and associated with primary sclerosing cholangitis or irregular beaded appearance on the biliary tree, which will need an ERCP for treatment. It also has autoimmune fibrosis of the intra and extrahepatic biliary ducts, which leads to jaundice. So that's PSC. Pruritic itching associated with HLA-DR52 in young men and increases risk of cholangiocarcinoma. Anorectal disorders of the upper canal, where the dentate is, that's where the endoderm meets the ectoderm transition point. The pectinate transition point has an increased risk of HPV infections, 16 and 18. Above the dentate line, it's columnar cells, and below it's squamous. Above the dentate, the columnar cells, autonomic nervous system stretch is innervated by the inferior hypogastric plexus, which only innervates stretch sensation. There's no pain. Above the dentate line, the lymph drains to the internal iliac, and above the line, the vascular drains into the portal circulation via the superior rectal vein, inferior mesenteric vein, portal vein, and so portal hypertension can lead to rectal bleeding that's painless. Below the dentate line, your veins drain into the inferior rectal vein, internal pudendal, and then internal iliac vein to the vena cava. Below the line, the inferior rectal nerve from the pudendal nerve innervates the sensation of pain. And for lymph, below the dentate line, it drains to the superficial inguinal. Dilated submucosal varices can cause hemorrhoids, which are dilatated vascular structures in the submucosa. Internal hemorrhoids above the dentate line, again, there's no pain innervation, so it's painless bleeding, and it coats the stools. It's essentially analogous to a sort of upper rectal varices. Much like you have portal hypertension causing esophageal varices, portal hypertension can back up through the anastomosis in the rectal vein and the mesenteric vein above the dentate line, causing internal hemorrhoids. External hemorrhoids, they do hurt because the somatic sensory is involved, but they don't usually bleed. Hemorrhoids on the external, usually seen in older people, opioid constipation or use of vincristine, or in pregnant women due to IVC compression. Because again, below the dentate line, the vein drainage system is to the vena cava. All right, let's talk about cancers. So we have colon cancer, which could be on the right side or left side. Right side is proximal ascending colon. Exophytic masses extend into the lumen, usually non-obstructive because the lumen there is so large. Right-sided colon cancer is associated with microsatellite instability, as well as mets to the liver. These are occult or hidden GI bleeds, which will manifest as feeling tired, fatigue, and on labs you'll have microcytic iron deficiency anemia. You'll have low ferritin, high TIBC. Left-sided colon cancer is left descending. It's usually ulcerative. It does cause luminal narrowing, and this time you see on imaging the apple core on CT or an enema due to the obstruction, the napkin ring. This will cause changes in bowel habits and obvious hematochezia. And this is more associated with the sequence of adenoma sequence. Make sure you do colon cancer screening, fecal occult blood tests, COX inhibition, CA markers only for progression or reoccurrence. It's not diagnostic. And then remember, 3% of colorectal cancers is from HNPCC de novo with no adenomatous polyps, and as well as Lynch syndrome, which also increases the risk for other cancers like endometrial, ovarian, stomach, hepatobiliary, and finally colon. The microsatellite instability, again, more on the right side, mismatch repair associated with the Lynch, and it's autosomal dominant. So it starts with one mutation, and then you have a gain of a second mutation. The most common cancer of the stomach is, that's right, adenocarcinoma, especially common in the Southeast Asian regions. It can mimic gastritis. So if you have someone with gastritis symptoms, it might not just be H. pylori, it could be adenocarcinoma. So you have two types. You have intestinal type, which is bulky, exophytic. This occurs in the lesser curvature of the antrum and pylorus. It starts out as metaplasia. So atrophic metaplastic gastritis is the biggest risk factor. Kind of analogous to how Barrett's esophagus starts with metaplasia there in the esophagus. Other risk factors for metaplasia are H. pylori, causing atrophic gastritis, autoimmune, causing autoimmune gastritis, and you can also have developing goblet cell columnar intestinal metaplasia. Other things associated with it are salt-preserved foods, smoking and alcohol, type A blood, nitrosamine, EBV, and FAP on chromosome 5, related to Turcotte and Gardner. So that's intestinal type adenocarcinoma, big, bulky, antrum pylorus, starts as metaplasia. Then you have diffuse type of adenocarcinoma, which is completely different. It has no mass effects, except for possibly early satiety, but its etiology is missing E-cadherin, which allows for disorganized cells that are not axophytic. They actually grow out laterally in a diffuse, disorganized manner. It replaces the soft folds of the stomach with tough, fibrous tissue, which is the desmoplastic reaction. You actually have this leather bottle stomach, linitis plastica, and loss of peristalsis. So if you have someone with gastroparesis, don't just assume it's diabetes. Consider diffuse type adenocarcinoma. You'll also see on pathology mucin, which is contained within vacuoles, or the signet ring sign. And this, in general, both of these types can metastasize from the stomach to surrounding liver, lungs, and Krukenberg ovaries. Warning signs include epigastric abdominal pain, nausea, vomiting, anorexia, and upper GI bleeding. Gastric lymphoma is the most common extranodal site for B and T cell lymphomas. They have marginal maltomas, as well as diffuse large B cell lymphomas. These occur with germinal centers and small blue lymphocytes. Risk factors are chronic gastritis and H. pylori. And the most common site of EBV-associated sporadic lymphoma is, in fact, the stomach. Think about the Burkitt's lymphoma. You can also have pancreatic adenocarcinoma, which causes jaundice and weight loss. And this adenocarcinoma is caused by smoking, chronic injury to your pancreas, like through alcohol, BRCA1 and BRCA2, which cause tumor suppressor gene mutations, CDKN2A tumor suppressor mutations, SMAD4 tumor suppressor mutations, and KRAS oncogenes. When it occurs in the head of the pancreas, it's retroperitoneal and involves a common bile duct, which is why it causes jaundice with light stools and dark pee, because of the excess bilirubin in the urine. You can have Courvoisier's sign, which is a right upper quadrant palpable non-tender gallbladder with jaundice. Weight loss, fever, night sweats, palpable left supraclavicular lymph node, periumbilical, Sister Mary Joseph, migratory thrombophlebitis, superficial vessel clotting and inflammation, where you have these cord-like palpable veins that are painful, pruritic, and red streaks appear in multiple places across time and space. And you can also have a Cushing syndrome with hypercortisol. If it's in the head of the pancreas, there'll be obstruction, but if it's in the tail of the pancreas, there might not be any of the obstruction signs. New onset diabetes, think pancreas cancer. Track the treatment with tumor markers like CA19-9 and CEA. Remember, CA19-9 can also be seen in cholangiocarcinomas. Pancreas can also have weird neuroendocrine tumors like an insulinoma, glucagonoma, or a gastrinoma, or a VIPoma. Insulinomas, just like the name says, you're going to have lots of insulin. So you're going to have hypoglycemia, tremors, confusion, sweating. Whipple triad, symptomatic hypoglycemia, low blood sugar, feels better after eating. You'll have high C-peptide levels, which is endogenous. Glucagonoma is the opposite. You'll have lots of glucagon. So you'll have hyperglycemia, new onset diabetes, diarrhea from all the osmotics, and weight loss. You'll also have a rash, a necrolytic migratory blistering erythema, which causes plaques with central clearing and a crusting periphery. You'll also have neurological signs like depression, dementia, psychosis, agitation, as well as clots like DVTs and PEs. Gastrinomas, you'll have lots of gastritis and GERD symptoms. You can have diarrhea as well as malabsorption. And refractory peptic ulcers, more often in the duodenum than the gastric, although sometimes in the jejunum. These gastritis symptoms are going to be unresponsive to PPIs. You're going to have prominent on pathology, you'll have prominent gastric fold thickening. Secretin, which normally inhibits gastrin release, will not be able to suppress the gastrin levels, which will be usually over 1,000. There's a association with MEN1, Zollinger-Ellison with MEN1. Menin is the tumor suppressor on chromosome 11, and then you'll have pancreatic mass, pituitary mass, and a parathyroid mass. Speaking of dysmotility associated with cancers, you can also have gastric dysmotility from other causes. So idiopathic parasympathetic cranial nerve 10 dysfunction, which causes impaired peristalsis, could be from surgeries like iatrogenic vagus nerve cutting, medication side effects like calcium channel blockers, TCAs, metabolic like uremia or hypothyroidism or diabetes, multiple sclerosis, or autoimmune like scleroderma. You can treat this with a vagal nerve stimulator or something like metoclopramide, which is a D2 antagonist. Be careful for malignant hyperthermia and EPS symptoms. You can also have Mentrier's disease, which does increase your risk of cancer. Basically, this is hypertrophy of the rugal folds due to hyperplasia of mucus-secreting cells. So all this hyperplasia and hypertrophy inhibits normal peristalsis. Essentially, there's excess mucus, which decreases how much acid there is in the stomach. No more acid means you can't digest proteins. So Mentrier's essentially leads to a protein-losing enteropathy. Less proteins means less immunoglobulins, so you'll have hypogammaglobulinemia, more at risk of infections. You can also have upper GI bleeding, hematemesis, melena, weight loss, muscle wasting. Low proteins means low albumin, so you'll have peripheral edema. You might even look like nephrotic or liver or heart disease. So Mentrier's is treated with cetuximab to neutralize the antibody against EGFR. You can have other gastric type tumors in the stomach. You can have tumors of the interstitial cells of Cajal, which leads to GIST tumors. You have c-KIT tyrosine kinase, which is treated with imatinib, RTK inhibitor. It's associated with CML 922 translocation, and it's the most common abdominal mesenchymal tumor. GIST tumors, interstitial cells of Cajal tumors, form from the connective tissue. So they're going to be well circumscribed, fleshy, and submucosal masses. And they'll have two types of cells, elongated spindle and the more plumper epithelial cell. You might have carcinoid tumors of the small intestine, most commonly in the ileum and cecal junction, also where Crohn's hangs out. And these arise from neuroendocrine cells, which release hormones and neurotransmitters. These will then cause carcinoid syndromes. On the right heart valve, you'll have vegetations on the collagen. You have bronchospasms with flushing, secretory diarrhea. The left heart is okay because the lung has MAO and enzymes, so the neurotransmitters will actually be broken down, and that's why you'll see the 5-HIA byproducts in the blood. Carcinoid can also happen in the lungs, thyroid, rectum, and colon. On histology, you'll see small purple cells, northwestern, with pink tissue, that's the connective tissue, and dense secretory granules that have yellow and fiber due to desmoplastic reaction, and hormones like serotonin, histamine, and gastrin. These are mostly asymptomatic but can cause obstruction, may cause appendicitis. Appendicitis is usually most commonly caused by fecalith, but it may be a tumor, and it may metastasize to the liver. Again, the most common appendiceal cancer is carcinoid. Before the liver, there's no active hormones because of the liver metabolism, but distal to the liver, they may metastasize and so cause the FDR carcinoid syndromes. Flushing because of the serotonin, and histamine, which causes vasodilation, activation of GQ IP3 calcium channels, nose and cheek telangiectasias. Bronchospasms and wheezing. It's not asthma, so avoid beta-2 agonists because on top of the beta because beta agonists on top of the carcinoid vasodilatation can lead to hypotension. The D in FDR is the carcinoid secretory diarrhea, causing hypovolemic contraction alkalosis. And you can have right-sided heart symptoms, which will be a holosystolic tricuspid regurg, a murmur, as well as pulmonic stenosis. Serotonin stimulates fibroblast growth and collagen, so you'll have valvular vegetations causing regurgitation initially, and then later, once they grow enough, they'll be causing stenosis. Test with 5-hydroxyindoleacetic acid measured in the urine, treated with surgery. And if you have high levels of somatostatin receptors, you can give octreotide, which is a somatostatin analog, to inhibit the serotonin release. Small bowel cancer adenocarcinoma otherwise is most commonly found in the duodenum. This will have glandular structures or bubbles in the primary proximal small bowel duodenum. It will start as a polyp, and you have increased risk with FAP syndrome, which is autosomal dominant, Lynch syndrome, which is autosomal dominant and it might not have any polyps, but FAP has many polyps. Remember, Lynch is mismatch repair microsatellite. You can have Peutz-Jeghers syndrome, which leads to hamartomatous polyps, and it is also autosomal dominant. And you can have IBD, which Crohn's disease and ulcerative colitis both increase risk, small bowel cancer risk. On the other hand, Peutz-Jeghers will also have other signs like mucocutaneous hyperpigmentation at the mouth, lips, palms, and other genitalia. And again, Lynch syndrome will have a constellation of cancers in the endometrium, colon, ovaries, hepatobiliary. Let's talk about bowel obstructions again. So the most common site of an obstruction is the small bowel. Most common cause is fibrous adhesions after an infection or surgery or inflammatory bowel disease. But other causes include the cancers that we just talked about, intussusception or gallstones or hernias. These will cause symptoms of nausea, vomiting, obstipation, intermittent abdominal pain that's on and off, and high-pitched sounds on auscultation. X-ray shows dilated loops of bowel with air fluid levels and a transition point between the proximal dilated bowel and the collapsed smaller distal bowel. This is different from ileus, where there's no transition point. There's uniform dilation, which includes the colon. From the paralysis or amotility, you'll have constant pain, and you'll have a distended abdomen and tympany, but nothing on auscultation. It's a broken boombox. This can be caused by gallstone ileus, hypokalemia, diabetes, sepsis, surgery, or drugs like vincristine, vinblastine, or even ischemia. Rare causes of bowel obstruction include SMA syndrome, which is compression of the third part of the duodenum between the aorta and the SMA at the L1 level. This compression can be due to severe or rapid weight loss, which essentially decreases the mesenteric fat pad, causing the transverse third inferior part of the retroperitoneal duodenum to compress on the SMA. The SMA may also compress the left renal vein, which can lead to a nutcracker syndrome. This is a recurrent postprandial abdominal pain, signs and symptoms, but this needs to be a diagnosis of exclusion. This is kind of analogous to the compression of the bile ducts in Merizi syndrome. So you can kind of remember two ways to remember, or one concept to remember two different things that'll sort of reduce what you have to remember. So bile duct compression with Merizi syndrome, SMA compression of the duodenum causing obstruction. I mentioned intussusception as being cause of small bowel obstruction. So this is a surgical emergency, which is telescoping and invagination of the mesenteric tissue. This leads to impaired venous return, which causes ischemia, leads to necrosis, lactic acidosis. There's a lead point, often the Peyer's ileum patch, where there's hyperplasia after a virus infection or a vaccine or a tumor. Essentially, you have Meckel's diverticulum polyps that can initiate this lead point in children and tumors in adults. The most common site is at the ileocolic junction between the ileum and the cecum. These symptoms are similar. You'll have a right lower quadrant, intermittent colicky pain, nausea, vomiting. The red recurrent jelly stools with mucus. You might even feel a mass at the ileocolic right lower quadrant junction, and you'll have on ultrasound a what appearance? A target appearance, or on sagittal CT, a sausage appearance. The treatment is a barium enema, which can diagnose and simultaneously treat the intussusception. So barium, treat the intussusception. Hernias. Hernias can also cause bowel obstructions. These are weaknesses in the fibromuscular tissues causing wall defects. Older men have a persistent processus vaginalis and a larger inguinal ring. You can also acquire this from increased pressure like heavy lifting, surgery, coughing a lot, constipation, or pregnancy. You can have a necrotic stuck bowel. Again, there's a similar theme in medicine. If you have something that's restricted or incarcerated, there's no venous return, so the compressed vasculature leads to distension and swelling, which leads to ischemia, necrosis, strangulation, ultimately perforation, sepsis. It's a surgical emergency. You can have a indirect inguinal hernia, which is the most common type of hernia. That's lateral to the epigastric vessels, into the inguinal canal, and through the external and the internal inguinal rings. And that's often caused by a failure to close the processus vaginalis. An indirect hernia is covered by all three layers of the inguinal canal, whereas a direct hernia is only covered by the external spermatic fascia. An indirect is covered by all three layers of the spermatic fascia, external oblique, internal oblique, and transversalis fascia. In men, the inguinal canal is for the gonadal vessels, and in women, it's for the round ligament. Again, let's talk about diarrhea. So the definition is stool with increased water content, volume, or frequency. It is also defined by the length of time that it lasts. Acute diarrhea is less than 2 weeks. Chronic diarrhea is more than 4 weeks. Big picture, you can have inflammatory or non-inflammatory diarrhea. The non-inflammatory diarrhea is subdivided into osmotic, greater than 50 osms, stool gap, secretory, less than 50 osms, stool gap. Differential diagnosis depends on how long it's been and the type of diarrhea. Infectious inflammatory causes could be viruses, bacteria, parasites. Non-infectious could be medications or other GI diseases. General approach is, does the patient really have diarrhea? Because this could actually be fecal incontinence or impaction. Sometimes opioids can cause that. You want to rule out medications as a cause of diarrhea, something like drug-induced diarrhea. Distinguish acute from chronic. Categorize it as inflammatory or fatty or watery, and then consider factitious diarrhea. If you have inflammatory invasive diarrhea, you want to consider something like Shigella, Campylobacter, Entamoeba histolytica, Salmonella, EHEC, C. diff, CMV, TB, or inflammatory diseases like IBD or UC, or something invasive like ischemic colitis. Fatty diarrhea is results from fat malabsorption like in celiac disease or SIBO, or after a cholecystectomy. You have fat maldigestion from pancreatic excrete insufficiency from chronic pancreatitis, or cirrhosis even. You might also see that with Whipple's disease, which will also have joint involvement, heart, lymph nodes, and CNS effects. Now, watery diarrhea could be osmotic or secretory, and this is the non-inflammatory type. Again, osmotic, greater than 50 stool osms, and this is caused usually after food. So something like lactose intolerance, could also be giardiasis or laxatives. Secretory diarrhea is usually hypovolemic and normonatremic, and this is a loss of a large volume of isotonic watery diarrhea. Causes of this can also be potentially an infection like Cryptosporidium or Vibrio cholera or ETEC. You can also have non-osmotic laxative loose like phenanthrene, which can cause melanosis coli, or peptide-secreting endocrine tumors like carcinoid syndrome in the ileum, which produces high levels of 5-HT. Other findings on osmotic diarrhea, you'll have a stool smear that's negative for fecal leukocytes, and a decreased stool pH because of the lactase deficiency. Secretory diarrhea, less than 50 osmotic stool gap, also negative for fecal leukocytes because it's non-inflammatory, and you'll have high 5-HIA indocilic acid degradation product of carcinoid syndrome, and you want to do microscopy because it could also be microscopic colitis. Let's talk some more about cancer. Colon cancer has an adenoma to carcinoma sequence most commonly. You start with an adenomatous polyp. After APC tumor suppressor gene mutation, APC gene products usually control beta-catenin, and they interact with E-cadherin. So if these are out of order, you'll have intracellular attachment issues, and epithelial cells will just grow outwards into the lumen wherever they please. The adenoma further continues to grow, activating continuing mutations in KRAS on chromosome 17, which is also seen in neurofibromatosis 1 and follicular carcinomas. It is a proto-oncogene that is GTP bound, causing unstoppable cell division, so polyps growing on a rat ass. Transformation to adenocarcinoma is after the adenoma penetrates the basement membrane. So penetrating through the city wall, you have the multiple tumor suppressor gene mutations to get to this. Chromosome 17 also has, in addition to KRAS proto-oncogene, it has the tumor suppressor P53, which prevents G1 to S phase transition, checkpoint for errors and apoptosis. You also have DCC, which is deleted in colon cancer, so you usually activates apoptosis as well, and this will be reflected in different types of polyps. So you have the adenomatous polyp, which is the most common type of colon polyp. It has a stalk. Its adenomas have adenocarcinoma transformation potential. The risk factors for transformation that I just mentioned is size, dysplasia, and if it's villous. So size greater than 1 centimeter, it's bad. You want to get a repeat colonoscopy soon. If there's high-grade dysplasia, disorganized, sort of nuclear hyperchromatic, elongation, stratified epithelium, nuclear crowding, that's dysplasia. You want to get repeat testing soon. If you have villous or sessile, those are large, long glands with villi projections and potassium-rich mucus. So that also has the highest malignant potential. So tubular is the least malignant potential. Tubulovillous is pretty bad, and then villous is the worst. You could also have sessile serrated polyps and adenomas, which are sawtooths all the way through. These are located in the proximal column. They do not have a stalk. They easily blend in because of their fat. They also have malignant potential. Familial adenomatous polyposis, or FAP, has many polyps. It's 100% penetrant, so you will get cancer at some point, so they need prophylactic colectomies. APC mutations can also occur outside the GI tract, though, and this leads to Gardner and Turcotte syndrome, Turcotte in the CNS, and this also increases the risk of gastric adenocarcinoma, or Gardner. Gardner syndrome has fibromatosis, which is a non-neoplastic fibroblast in the retroperitoneum. This can be related to bone osteomas, skin cutaneous lesions, hypertrophy of the retinal pigment epithelium, and dental abnormalities. And Turcotte syndrome is medulloblastomas of the brain. You can have non-neoplastic hamartomas, sometimes seen with GI bleeds. So you have happy hamartomas, but they do have an association with the increased risk of CRC. So you have mature cell types at the site. So a hamartoma can just be of any cell type, so it's a mature cell type, but it develops in a disorganized fashion. So you can have connective tissue, smooth muscle, glands that are mature and benign and happy. You can have glands filled with mucin or inflammatory debris. You might even have rectal and might even prolapse through the anal sphincter. Examples of hamartomatous non-neoplastic types are Peutz-Jeghers, which is autosomal dominant, has a serine threonine kinase tumor suppressor mutation. That causes mucocutaneous hyperpigmentation, as well as seen in small bowel cancer, small bowel obstruction, and intussusception. You can also have juvenile polyposis, which is the most common type of hamartomatous polyps. It's also autosomal dominant. It literally has hundreds of stalked pedunculated polyps like seeds on a stalked berry. It has increased risk of colon adenocarcinoma. And then you can also have a hyperplastic polyp, which is also non-neoplastic. Hyperplastic polyps in your age 60s and 70s are benign. They usually have abundance of goblet cells, and crypts retain their smooth shape, and they're only serrated at the top. Juvenile polyposis with Cronkite-Canada syndrome usually includes fingernail dystrophy. Let's talk about cirrhosis. Once you have cirrhosis, it's irreversible. It can be caused by alcohol, most commonly hepatitis B, C. That's macronodular. Alcoholism is most common, causes micronodular. You can also be fatty or non-alcoholic fatty liver disease, autoimmune, PBC, PSC, alpha-1 antitrypsin, hemochromatosis, and Wilson's disease. The pathogenesis for the fibrosis is stellate cells or Edo cells in the perisinusoidal space, or the space of Dissay, become activated into myofibroblasts. Thanks to TGF-beta, this creates regenerative nodules with fibrosclerosing collagen bands. Because these are perisinusoidal, eventually the sinusoids become compressed. This increases the hydrostatic pressure in the portal venous system. Essentially, the fibrosis shrinks the fenestrations, decreases exchange of solutes, portal hypertension, there's less detoxification, less synthesis, more buildup of toxins. So let's talk about the synthesis issue and the toxin issue. Less synthesis. You get bleeding and edema and less vitamin D and fasting hypoglycemia because you have coagulopathy. You're not able to synthesize platelets, so your INR goes up. You can even measure this liver function by following the clotting factor 7. You don't have as many clotting factors. You have edema from low oncotic pressure because your liver isn't making albumin. So you have excess RAS activation leading to aldosterone and hypokalemia. And because you don't have as much albumin on, you don't have as much total calcium. You have more free ionized calcium. You also have less synthesis of hepcidin, and you have less synthesis of 25-hydroxylase. Remember, you have vitamin D in your skin, which gets converted into 25-hydroxylated D, 25D, which then goes to your kidney, and then it becomes 1-alpha-25D, and then that becomes activated. So essentially, you can get osteomalacia, osteoporosis. And then finally, your liver helps produce glucose through gluconeogenesis or glycogenolysis, and you have fasting hypoglycemia. Furthermore, you have the problem of toxins. So toxins, you'll have less detoxification. So you have mixed unconjugated and conjugated bilirubin excess causing the jaundice. And you'll have hepatic encephalopathy because there's more ammonia and there's less urea cycle. So you'll actually have low BUN. Altered mental status, seizures, sleepiness, coma, asterixis, aromatic amino acids, which are false neurotransmitters instead of being metabolized into urea. You'll have treatment for that as rifaximin to stop the intestinal production of ammonia, and lactulose, which is a non-absorbable sugar, to lower the intestinal pH, trap ammonia in the bowel as NH4+. You have less detoxification, so you have more estrogen on board, which leads to the pulmonary erythema, gynecomastia, more sex hormone-binding globulin, therefore decreased testosterone. You'll have more thyroid-binding globulin, therefore you could have hypothyroidism, spider telangiectasias as well. And finally, the end product of cirrhosis is portal hypertension, which can have numerous consequences like varices, both esophageal and hemorrhoid. You have retroperitoneal splenic varices, superior rectal hemorrhoids, epigastric, caput medusa, and splenic congestion, which leads to splenomegalia, hypersplenism, consuming red blood cells and platelets, leading to a non-immune thrombocytopenia, petechia, early bleeding. You can treat varices with PPIs, beta blockers, mononitrates, and then SBP prophylaxis with antibiotics and octreotide. And if you have ascites due to less oncotic pressure, you have portal pressure, which pushes the fluid out of the endothelial space, which overwhelms the lymphatic system, leading to a positive fluid wave on the peritoneal cavity. And may cause SBP due to the protein-rich ascites fluid. You remember you have portal hypertension has a high SAG and will cause fever, abdominal pain, altered mental status, and greater than 250 neutrophils per field is diagnostic. Two syndromes associated with cirrhosis you need to know about are hepatorenal syndrome. Essentially, this is caused, again, by splanchnic vasodilatation, which shunts blood to the gut and the portal vein, and less blood to the kidneys. The kidneys, macula densa, sense less fluid, so they release RAS, leading to angiotensin II vasoconstriction and further decreasing GFR. And then hepatopulmonary syndrome, which again, there's vasodilatation due to more nitric oxide release. There's VQ mismatch because the oxygen cannot diffuse into all the blood. And you have dyspnea on exertion, finger clubbing, and you have dyspnea that's worse sitting up. And that's because the dilated capillaries are at the base, and there's going to be less oxygen getting to that VQ mismatch area and the dependent areas where the blood is pooling.